Okay, so we're going to be talking about mental health. And this is like in three parts. So we'll start with mental health. Then we'll move on to another PowerPoint I did on physical, sexual, and kind of neglect. And then last, child maltreatment in primary care. It's a PowerPoint or a lecture I did at a conference. I just thought it was easier and made more sense. So here we go. Hopefully this works out well. So when we're talking about mental status, not only is somebody have a psychiatric issue, but they could also have abuse, some kind of abuse. As we know, drug and alcohol abuse is also in the DSM-5, and it may be 6 now. So we're looking at, when we think about a disorder, is this a significant behavioral or is there a significant behavioral or psychological pattern? Is there distress or disability? Is the distress a painful symptom? Is the disability impaired functioning? So now it could be organic, so it could be a known cause like delirium, dementia, like I mentioned, some kind of alcohol or drug abuse, or it could be an etiology that we don't know when it comes to a psychiatric mental illness. It can be tricky because if the patient isn't, I know in my practice, because I'm in private practice and we don't have a lot of resources there on site, so my patients have to be somewhat self-aware that they have a mental illness. If they don't, if they truly believe something is organically wrong or physically wrong, and based on their behavior and their thought processes, it's clear to me there is not, and that they may have a mental illness. If they don't agree, we're not going to get anywhere. So it does make it hard. I can think of one example of a middle-aged woman who clearly thought she had a parasite and didn't understand why nobody could find it. Even though I was like her third or fourth primary care that she had hit or changed to, and nobody could find this parasite, which really didn't exist because everyone had checked her stool, her sputum. There was nothing in it. Even when she tried to Google and came up with a parasite that she believed she saw, it didn't work that way. So it just makes it extremely tricky and difficult. So when we define mental status, we're looking at its functioning is inferred through the assessment of these behaviors that the patient has. So these are the things that we're assessing as we're looking at the patient who we believe may have a mental illness. Their consciousness, their language, their mood and affect, their orientation, their attention, memory, abstract reasoning, thought process, thought content, and perceptions. But before we start to break that down, I want to just take a moment to look at the prevalence. And let's start with alcohol. So alcohol use disorder, AUD, as looked at through the National Survey on Drug Use and Health. In 2015 showed that there were a little over 50 million adults who were diagnosed with AUD. And of those 15, almost 10 million, 9.8 million were men and 5.3 were women. And when we look at the ages of 12 to 17, 623,000 adolescents are diagnosed with AUD. And you can see the prevalence is greater, a little bit higher for female adolescents than males. About 88,000 people die of alcohol-related causes, which make it the third cause of preventable death. And in 2014, almost 10,000 deaths were caused by alcohol-impaired driving. And in 2010, alcohol misuse cost the United States $249 billion. So it's a very expensive disorder, and it's pretty prevalent. So we know, and it's clearly been established, that the more alcohol use, the greater the risk for liver disease, cirrhosis, or cancer. But we also see an increased risk of breast cancer by 4% with increased alcohol use. Heavy drinking and binge drinking are also associated with increased risk of AFib. Hypertension can be a common effect of AUD or alcohol abuse, and there's an increased risk of sepsis, septic shock, trauma, hypothermia, pancreatitis, and hospital mortality with alcohol use. So alcohol is the culprit or the cause of an increased risk in many things. So let's look at a little developmental differences. So with pregnancy, 80% of pregnant women will use alcohol in their first trimester. My theory being that a lot of these women don't realize they're pregnant, so why it's so high. So once they realize they're pregnant, as you see, the incidence drastically drops, with only 4.2% drinking during their second trimester and then 3.7% in their third. We're still not sure how much alcohol is safe or unsafe. So the recommendation is that women should not drink once they realize they're pregnant. And all pregnant women should be screened for alcohol and drug use, because we know the potential adverse consequences of alcohol use in the fetus, fetal alcohol syndrome. So it's important that women abstain. However, there are some women that will still drink a little bit, even though we don't know the theory. Excuse me. I still have this stupid cold. You know, the thought being that a little alcohol is okay, but we don't know. But when we look at the aging adult, so somebody 65 and older, the prevalence of current alcohol use decreases as somebody gets older. So only about 41.2% of elderly patients even drink, 8.2% binge drink, and 2% are heavy drinkers. Oh my goodness. And then with older adults, there's some characteristics that can increase the risk of alcohol use, being that their liver metabolism and their kidney function will decrease. So increasing the availability of alcohol will last longer in their bloodstream, so it could affect their liver and kidneys. They have less tissue mass, so alcohol concentration is increased in their blood. And most elderly patients typically are on multiple medications that can interact with alcohol, such as benzodiazepines, antidepressants, antihypertensives, and aspirin. And of course, anyone who abuses alcohol is at a risk of falling, but elderly, even without the alcohol, they may be at risk. So the alcohol increases the risk of falls, depression, and gastrointestinal issues. So when we are assessing our patients, when we're talking about substance use, one of the things we have to think about is, what is a standard drink? So here you see that a standard, whether they drink beer or maybe malt liquor or wine or whiskey or some kind of, a shot of gin, rum, tequila, vodka, or whiskey. This is a standard amount. So either 12 ounces of beer, 8 to 9 ounces of malt liquor, 5 ounces of wine, or 1.5 fluid ounces of a shot, or about 2 ounces. They're all considered a standard drink. And for women, they can have 1 standard drink a day. Men can have 2 and still be considered safe. So when I'm getting a history from my patient about their alcohol use, and I ask them, do they drink? Yes. How much do they drink? And I'll usually ask, do you drink beer, wine, shots, or mixed drinks? And then they'll tell me, which one they typically will drink. Some patients will do all of them. They just kind of will do it all. Some will stick to beer or wine or something like that. And then when I ask how often, if a patient will tell me, even if they're drinking like a mixed drink, like a, margarita or a martini or whatever, and they say, oh, I only, I don't drink that often. And when I ask them to quantify it for me, and they say, if they're telling you they drink every other month or every 3 months or, a couple times a year, or, or just with, I've had patients tell me, I just do it on New Year's, then I don't get that excited. I'm like, okay, this patient really isn't drinking that much. Even if you double that, it's not that much. So, I will make note that they have 1 or 2 drinks every, 6 months or every 3 months or twice a year or whatever. However, if they're telling me they're doing, yes, I drink and how often, and they say, oh, I'll have, 2 or 3 drinks a week, then I want to break it down. Like how much are you doing? Because you can say, oh, I drink a glass of wine. Well, is that a 5-ounce glass of wine? Or is that a 6 ounce or 7 or 10? Are you filling the wine glass to the top? So you need to know. Because, like, for instance, let's say they do beer. So are they doing a 12-ounce can of beer? 1 beer a day. Okay. Or are they doing a 24-ounce a day? Or are they doing a 40-ounce a day? Let me know. Some guys, especially men typically, will say, oh, no, I don't drink that much. I only drink on the weekends. Oh, okay. Well, how much do you drink? Oh, I'll drink a 24-pack. Okay. Well, let's do the math, shall we? Okay, so you're doing a 24-pack on the weekend, which is 12-ounce cans of beer, and typically in a 24-pack. So that's 12 times 24, which is 288 ounces of beer a week. Which, if you break it down, could mean about 1 to 2 beers a day. Okay, but you're doing it in a concentrated, so it's more like binge drinking, in my opinion. If you do 24, or I've had patients say, oh, I don't drink that much. I'll do a 6-pack a night. Okay, do that math. That's 6 12-ounce bottles of beer a night. So if you figure that out, so that's 12 times 6, which is 72 ounces a day, and you're doing it every night, 7 days. That's 504 ounces of beer. That's a lot. And then when you tell somebody that, it's a lot different than them thinking, oh, it's just 6 cans of beer. What's the big deal? So, and then you have to think, what am I worried about? Not only is the guy drinking a lot, but what kind of health issues is he going to have? Or do I need to check? So, now let's talk about illicit drug use. So, about 9.5% of Americans 12 and older reported current illicit drug use. So even in my practice, a lot of my patients will use marijuana, smoke a lot of weed. So that's marijuana or hashish, cocaine including crack, heroin, hallucinogens, inhalants, and prescription drugs. So 1 out of 10 adolescents are using illicit drugs. My peds patients, typically if they're doing anything, they're smoking marijuana. They're not taking, at least they don't disclose any other use. So, which again is not great, but I'm not typically as kind of worried. Okay, so, but even illicit drug use has serious consequences for health, relationships, future jobs, school, and career. And as we all know, there is an opiate epidemic. Well, if you didn't know, there is one in the United States. It's on the news, social media, everybody's talking about it. They didn't talk about it that much when their crack epidemic was killing everybody, but because these are prescription drugs, I guess, it's become a big problem. Even in where I live in Sacramento, a few months ago, patients were dying because they were buying hydrocodone off the street, and it was getting cut with fentanyl. They thought they were buying Narcos, and they were actually buying fentanyl, which is much more potent, and they were dying from it. So the most frequent abused prescriptions are oxycodone, hydrocodone, and methadone. I have one patient that takes methadone, low dose, for pain, but and I typically did not prescribe. I never prescribe oxy, but I did prescribe hydrocodone or Narcos or Vicodin. But even I stopped doing that because patients will just get irate and scream at you if you're late sending their prescriptions. Oh my gosh, which clearly shows that they're addicted and dependent. But it can get extremely ugly. Okay, so when we're trying to screen or assess the patient for mental status in their examination, we are going to do it in a systematic way, and we're going to be looking at these 4 headings of mental status: A, B, C, T: appearance, behavior, cognition, and thought processes. Okay, so they're, yeah. So that's the objective data we're going to be looking at. Sorry about that. Their appearance, their behavior, cognition, and thought processes. So as we go through this, we will look at posture. Is it erect? Is it relaxed? Are their body movements voluntary, deliberate, coordinated, smooth, and even? Are they dressed appropriately for the season, for their age, for their gender? Are they groomed appropriately? So is their, are they clean? Is their hair neat? Is their clothing like disheveled or bizarre or in poor repair? You can have, sometimes, are they, their personal, their body hygiene. Sometimes that can be an issue. So are they disheveled? Their level of consciousness. Are they awake, alert? Are they aware of the stimuli in their environment? Are they handling it appropriately? Is there facial expression? Remember when we talked about when we did our HEENT? So is their facial expression appropriate to the situation? And is it changed appropriately as they talk about the topic? So like if a patient is disclosing something that's very stressful for them, be it whatever, maybe some kind of abuse, and they get tearful, that's appropriate. So is their speech, normal? Is it effortlessly? Are the sounds effortlessly? And are they sharing is their conversation appropriate? Is the pace normal? Is the stream fluent? Are they articulating their words clear and understandably? Is their word choice effortless and appropriate? Are they speaking in complete sentences? So how is their mood and affect? Some patients will have a flat affect and they'll be kind of monotone. So that could be their norm, but you want to judge their body language, again, their facial expression. Are they appropriate to person, place, and condition? Are they cooperative? Orientation, meaning are they alert and oriented, like we did last week when we did our neuro assessments? So do they understand where they are? This is kind of more hospitalization, So those patients sometimes will get disoriented, but you could have it within your practice. You have somebody come in the outpatient setting and you may have to assess whether they're oriented to person, place, and time. How's their attention span? Are they able to concentrate, or do they tend to wander within their conversation. So they're not their attention span is very short. So are they anxious, fatigued? Are they intoxicated? When you see them are high, sometimes patients will come high as a kite. Is there recent memory, so they recall things that happened yesterday? So is there intact? Is there remote memory intact? So which can be, how do you validate that? Because you're not with the patient, you weren't with them like 10 years ago or even yesterday. So one thing that you can do is this 4 unrelated words test. So you get 4 words that are totally unrelated. They're not semantic or phonic, relatable, or they're diverse. I came up with 4 words like apple, ball, couch. What's one more word? Door. So apple, ball, couch, door. And you say those 4 words, you make sure the patient understands them, and then you ask them to recall them at 5, 10, and 30 minutes. So if they are younger than 60, they should be able to recall the words, at least 3 or 4 of the words at each mark. Elderly patients may have a harder time. So, and then we're looking at their judgment. Do they have the ability to compare and evaluate alternatives and reach an appropriate course of action? You can test it, about daily and long-term goals, and the likelihood of acting in response to hallucinations or delusions. You can ask the patient about their job plans or social or family obligations, plans for the future, their health care, and are they able to be compliant with it, and how are they going to do that, and do their decisions seem to be realistic. And then when we think or assess their thought processes, are they logical, goal-directed, coherent, relevant, thought content? Is it consistent and logical? So is the patient saying things that are consistent and logical? And their perceptions, are they consistently aware of reality? Their perceptions should be congruent with yours. And when they're not, maybe something's going on. So we also want to screen the patient for any kind of suicidal thoughts. So especially when they express feelings of sadness, hopelessness, despair, or grief, we need to see if they're going to hurt themselves or others. And you can begin with some general questions. I typically will ask if a patient is telling me that they are going to hurt themselves, or feel like they'd be better off dead, or their family would be better off if they were dead. I usually will ask, do you have a plan? And then if they say, no, I don't have a plan, it's not uncommon when you're feeling depressed to think life would be better if you just weren't there. But as long as you don't have a plan, like I'm not going to go out, I don't have any pills I'm going to take, I don't have access to a gun, I'm not going to go stab myself, I'm not going to, then it's not as concerning. I realize this patient needs to be treated and they need help and stuff, but I'm not worried as much that they're suicidal or homicidal. They don't plan to go kill somebody. But if they say, no, I have a plan, and it's interesting, patients sometimes will just tell you, they're, in my experience, to be honest, they're pretty truthful. And so they'll just be like, oh yeah, I got a plan, I have a gun, or I'm going to hang, or what. Nobody's ever said, I'm going to go shoot myself, or I'm going to hang myself. But if they say, yeah, I have a plan, and they kind of explain what they're going to do, that's a totally different scenario, and that one you need to deal with. Providers do it in a number of ways. If a patient they feel has some suicidal thoughts but no plan, they may have them sign a contract. They may have to come every day. They may have to, so it just depends on how well you know the patient and what's going on with them. I've even I think I only told one patient, like if she didn't come for her appointments, I was going to call the police and they were going to come to her house. So she couldn't just like blow me off because I was serious as a heart attack and she knew it, and she showed up for all her appointments, and so she was doing well. So it just depends on how you handle it. So it can be difficult to question patients because you feel like you're invading their privacy, but you don't want to skip these questions because it's part of your job. And if you do and the patient does something, people are then asking, did you screen them? So you do want to make sure you determine whether they have any suicidal ideation. And then I really love assessments. Oh my gosh, I love questionnaires. So these are the ones that, the top two is the ones I use in my practice all the time. So, and I have put them on Canvas so you can download them and have access to them and use them in your practice, when you start your clinicals and when you start to work. So the PHQ-9 I use for depression, and then the GAD-7 for anxiety. Now, I find that if my patient comes to me and says, I'm really anxious, and I went to the ER, and unfortunately the ER will always give them a benzo. That's not my go-to drug when I treat anxiety, but I also screen them for depression because I find that most of the time their PHQ-9 is positive and they have moderate to severe depression. So I will put them on a medication that will treat both their depression and their anxiety. And then I will try other medications. I don't like to use benzos because they're addictive. And then you got to try to get the patient off of them. So I'll use other things until the antidepressant kicks in, which takes 6 to 8 weeks. And I warn everyone that they might feel better in a couple weeks, but typically it takes 6 to 8 weeks. So I usually will have my patient start on the medication, and then they'll come back in 2 weeks, and then in a month, and then we kind of go from there. Of course, I work them up for any organic issues, so I will do labs, a CBC, a chem panel, a thyroid, TSH, T4. I do all those just to rule out anything organic that not so much causing the depression, but maybe making it worse because it's gone untreated. Now, the audit questionnaire and the gauge is for alcoholism. I haven't used that as much. I might start using that more. And then the tweak score is for those OB patients that you are screening for alcoholism. And then the SMASC G1 is for elderly patients who may have alcohol issues. So those are all these assessments for alcoholism and depression that you can use. So they're great. I love them. Now, if you have an elderly patient and you're worried about memory issues, so which can also be part of, mental health. Now, a lot of people will use the mini mental exam, which is about what's that, like 10 questions and stuff. And this isn't as sensitive to really determine whether or not the patient has like dementia, like Alzheimer's or some kind of dementia, like our Lewy bodies. So, which we'll talk more about when you do pathophysiology. But you can do this one. I started because I talked to a colleague, an NP who worked in neurology, and she was telling me that the Montreal Cognitive Assessment, or the MOCA, is more sensitive because it breaks it down into visual, spatial kind of things that patients have to do, and then naming and memory and attention. So they have to do all these different activities. And the instructions for both are on Canvas. So, for instance, the visual spatial, they have to go from 1 to A, 2 to B, and then B to 3, 3 to C, so it's like going 1, 2, 3, 4, but ABC, but you have to kind of do it that way. And try, when you explain it to them, it doesn't, Now, the patients I have used this on, they don't speak English, so it gets a little tricky. Because this is set up for English speaking patients. So, then their families have to interpret for them. So, I'm not sure how accurate the score is, but it was significant enough that I deemed that they probably had some dementia going. They have to draw that cube, and it has to look exactly like the cube in the picture. And a lot of times they can't put all the lines in and connect them. They have to draw a clock. And put all the numbers, and then I tell them a time. So they put the numbers down, then I'll say, using the long and short arms, draw this time on the clock. And for the most part, a lot of people can't do that. Name the animals, do the memory, like we talked about that 4-word test. They have to do all these words, and then they'd have no relationship, and then repeat them in 5 minutes and that kind of thing. So what you see in somebody who has, especially Alzheimer's, their clock will start to get weird. Like, this is like a normal clock, and then if they're mildly cognitive impaired, the numbers are in the right, but the time is off. Like, one arm may be long and the other one, or they're the same size. And then I know with Alzheimer patients, all the numbers will get squished on one side. They can't even put the arms on. So things like that. So you can see as their cognitive impairment gets worse, how things will change. There's a great book, if you, I know, like in your spare time. It's called Still Alice. There was a movie a few years ago so you may have seen the movie, but the book is great. If you get a chance, I really highly recommend the book, because it talks about a character in the book has early onset Alzheimer's, and some of these things the author put in there so you can clearly see. And I have a good friend whose mom has Alzheimer's, and she said her mother, when she did this test, that looked just like that clock in the book. So those are kind of things you have to think about, and that we screen our patients for when we're screening them for mental illness or their mental status. Okay.